Good morning, everyone. Thank you, Musa, for introducing me. If Musa had introduced me next to the Member of Parliament from my region, I think I would be in trouble. It's good to have all of you here today. From morning, we have been talking about eye health in regards to children. And indeed, in one way or the other, we are parents, or we are caregivers, we are aunties, we are uncles, we are daughters, we are sons to parents and all that. So it's important for us to all be here and contribute. But the most important thing is that we have experts in the room whom I'm privileged to introduce and who are going to be having discussion with us today on their key technical areas. I would like to introduce, when I introduce you, I kindly request that you'll move up and take a seat. Allow me start with Dr. Naomi Nsubuga. Dr. Naomi, please come forward. Dr. Naomi is a graduate from the College of Optometry at Salas University, United States of America. She's currently an optometry lecturer and the head of Department of Allied Health Sciences at the College of Health Sciences at Makerere University in Kampala, Uganda. She has a broad portfolio that if I begin to talk about, we will all remain here. So Dr. Naomi can be followed on LinkedIn. Allow me also introduce Professor John Onyango, who holds a Master's of Medicine in Ophthalmology and a fellow pediatrician. He has expertise of working in other regions in Africa, including Tanzania. He's a senior lecturer and is the head of ophthalmology department in MAST. Doctor, we're also honored to have you. We have with us also Dr. Rebecca. Dr. Rebecca, please, let's have you. Dr. Lusobia Rebecca Clare. I hope I pronounced it well. She is a senior lecturer and pediatric ophthalmologist and Department of Ophthalmology School of Medicine, Makerere University. She heads Directorate of Research, Ophthalmology Department, Makerere University. Previously, she has been a treasurer, Ophthalmologist Society of Uganda. She's a part-time lecturer, Department of Ophthalmology, Makerere University. I don't want to leave this one out. She's a medical doctor at Kumi Hospital, Ongino. Was, yes, previously. So that is at our heart because we know when we talk about services in certain communities, you just heard here earlier on that some of the services do not reach the rural communities. And for that passion of taking it that extra to a community that couldn't have the opportunity, we're also privileged to have you. Lastly, allow me welcome Dr. Alex. Alex, your other name. Dr. Alex is here. Yes, Dr. Alex, you'll join us up. You just heard from him a few minutes ago. That is Dr. Alex Wasomoka. Is that correct? Yes. Dr. Alex? Yes, fine. Thank you. He holds Bachelor's of Medicine and Bachelor of Surgery, Master's of Medicine degree in ophthalmology with postgraduate diploma and also healthcare leadership model. He's Assistant Commissioner, Hospitals and Lower Level Health Facilities and National Eye Health Care Coordinator. So it's a privilege and an honor to have all the distinguished experts with us here today. We are going to go through a round of questions which is tailored to each and every expert we have here today. And we're privileged to have them because in most cases you would be consulting them in either private hospitals or even our national regional referral hospitals, but make a long queue for that. Thank you very much, and let's stay tuned as we continue to listen. So allow me start with Dr. Naomi Nsubuga. How can we enhance vision screening and diagnosis in infants and young children based on your expertise?
Thank you very much for that question, and thank you to Let for the Word for the opportunity to be here and have this discussion around child eye health. First of all, child eye health is something that is dear to me. It's one of my interests because I'm a beneficiary. I was identified with refractive error in P6 by a teacher. So school eye health is one of those things that I am passionate about, and child eye health, because I was lucky, and then we have to go and find the rest. For vision screening and diagnosis of infants and young children, this is something that takes a collaborative effort. You cannot do it alone as a healthcare worker. You cannot do it alone without the support of teachers, without the support of people in the community, the nurses, the village health team, the community workers. All these people, we have to work together when it comes to identifying and screening the children, because they're not all in school. Some of them are out of school. In the community level, we have our families. We have, of course, the government team, the village health team or community health workers, who we can work with to help to identify any children in need. They know who is in the community. They're familiar with the parents, and therefore they can help us find these children. Another area is schools. Those who are in the school, that is a captive audience. We can identify, with the help of teachers, the children who are having trouble seeing, as well as those who are not performing well in school. We've had children who have been sent, and this is not just in low and middle income countries, but even overseas. I've seen children overseas who are sent for attention deficit disorder and things like that. They're not paying attention in class when all they need is a pair of glasses. They're not paying attention because they can't see what the teacher's writing. So we need to work closely with the teachers. They can help us identify these children. And in the health facilities, we have our nurses and we have our midwives. Again, we can work with them. They usually see the child from birth, at birth, and then during immunization. Immunization areas are very good at catching these children and getting them into the system. Ideally, at birth, they get the first eye checkup, and that is at the delivery. And then we try to see them around before they go to nursery school to catch any kind of early problems, identify them, and get the services to them. Then when they start going to school, we have been working very hard over the last few years trying to get eye health incorporated into school health programs, and together with the Ministry of Education, and that is in the works. We're waiting for the school health policy to be launched so that that can take part, so that every child who goes to school gets their eyes checked. And to strengthen the referral network between health, education, and the community. These are very important. Like I said, we have to collaborate so that we can identify as many children as possible, wherever they are.
Thank you very much, Dr. Naomi. It's very clear that we don't work in isolation, like she has mentioned. A lot of collaborations happen, but also it's key to note that from childbirth, there's also the importance of having children checked. And we appreciate all the information as far as the issues of eye health conditions in children and also screening processes are concerned. This will go to Professor John. Prof, what are some of the most common eye conditions you usually see in children and adults in Uganda, and how do they affect one's quality of life? Because you heard Musa's story, you've heard stories from many other people who are having visual impairment or issues with their eye, and this has also contributed immensely to their quality of life. would love to hear you share your expertise in that area. Thank you.
Thank you very much, moderator. There are a number of eye conditions which affect children. I'm going to talk specifically about children first before I talk about adults. But I will maybe lay emphasis mainly on those ones which will cause visual impairment and blindness. Actually, the commonest cause of visual impairment in children in our setup is refractive errors. These people will need glasses. That's the most common one. So very many of our children get refractive errors, and they are at school, they are not being identified, and I'm glad that this project is here to identify them so that they are corrected for them to pursue. The other causes, of course, is cataract. Childhood cataract is a very common one, as we are seeing an example of Greta here. So these are examples of very many common causes of blindness in children. Unfortunately, for this group of children, majority are there in the community, not identified, and they are not receiving this kind of services, and they have grown blind. I will talk about that one later, probably. The other one, of course, is the childhood glaucoma. Is another common eye condition which causes blindness in children. And they are there, most times they don't have the services too, and the majority have grown blind with very big eyeballs, and they can't see. The other one, which may not be very common, but is very dangerous because it is fatal, it kills, is retinoblastoma, cancer of the retina of the eye in children. And these children are everywhere. Unfortunately, the treatment centers for retinoblastoma are not everywhere in Uganda. We have a center at Mulago Cancer Institute. We have a center in Barra at Ruharo Eye Center. But children from far part of the country don't get access to these services. And the number of them, this one doesn't only make them blind, but kills. So a number of these children actually die because of retinoblastoma. There are other less common conditions like squints of the eye and so on. But there are also congenital problems in children which makes them blind. Very many children are born with congenital abnormalities. Some, like the eyeballs, are not developed at all. They are also there. And those ones actually don't need any treatment, actually needs to be rehabilitated straight. And of course, some eye injuries. That is also a very common cause of visual impairment and blindness. In adults, of course, just like we have seen from the RAP surveys which have been done recently, the commonest cause of blindness in Uganda is actually cataract. Yes, that's in adults. Followed by glaucoma, and we still have trachoma in a number of places. For example, in Karamoja, in Busoga. I think they have done interventions, but I don't know whether they have really been eliminated, but I don't think Uganda has been declared trachoma free, so I believe they are still there. But a number of people have already become blind from trachoma. Refractive error is still also a problem because of visual impairment and sometimes even blindness in adults. There are also emerging diseases, diabetic eye disease. We're having diabetic retinopathy, diabetic cataract is another emerging eye disease, actually, which we need to tackle properly. And then, of course, there are also other age-related retinal diseases like macular degeneration. These are common causes of visual impairment and blindness. The quality of life in these people are affected, especially in children. A child born with a cataract, for example, if it's not operated early, before the age of 8 years, is condemned to lifelong blindness. And that means that this child is going to live the whole of his or her life with blindness. And you can imagine the opportunities this child will lose in terms of education, in terms of social life, in terms of even employment opportunities. So blindness is a very big problem which can affect the quality of life for somebody. Actually, it is believed that even blindness is directly related to mortality. When you are blind, your lifespan is reduced. They die earlier than the rest of the people. So this is the kind of quality of life these people undergo through when they become blind. Thank you very much.
Thank you, Professor. I think we're all probably sitting here and especially for me, I'm sitting here and asking a lot of questions, and I hope you're doing the same. As parents, what is your role? As society, what role are you playing? What information are we giving out there? Even us who have the platforms we are still not aware of some of these conditions. And also to get to know that by 8 years, if not operated, it can lead to death and permanent blindness in some cases. So at the end of this, or when we have opportunity to ask questions and reflect, let's reflect on what is our role in ensuring that we're avoiding or mitigating some of these factors. Thank you, Professor. My next question would go to, back to you again, Professor. It's around the barriers that exist in providing ophthalmology services across Uganda's various regions, and also how can we bridge the gap. I clearly heard you saying that some of these opportunities are not there in some of the regions, up countries, so I think you can echo more on this. Thank you.
Yeah, thank you once again. We evaluated the fourth eye health plan in 2019. That formed for us the basis for the development of the fifth strategic eye plan, which we are currently implementing. And that one also gave us opportunity to evaluate the implementation of Vision 2020 program. And the key areas which we evaluated were areas of human resources. And actually, this is a big problem in the implementation of eye care in Uganda. For example, as I talk right now, out of, I think, 16 by then, I don't know whether they are now increased, regional referral hospitals in Uganda, only 9 have an ophthalmologist. 9. The remaining 7 do not have an ophthalmologist. When you go to West Nile, where there are 2 regional referral hospitals, Arua and Yumbe, there's none. So how can you expect eye care service to be delivered in a region, a whole 2 region, without any ophthalmologist? So that is a very big gap. The same occupies with the mid-level cadres, the OCOs. Only about 60%, that is one at least. There is supposed to be an OCO in every health sub-district and district hospital. But you find that they are not there. And when they are there, they are actually not even practicing eye care work. They are either doing circumcision, they are the head of TB, and so they are not doing any eye care work. So despite, I say 60% of them are recruited, but they are not doing eye care work. So the human resource for eye care availability is actually the biggest problem in the provision of eye care in Uganda. And that also affects the quality of the data which comes to the ministry, because there is no data coming to the ministry. Yeah. The second one, of course, is equipment and consumables. There are a number of regional referral hospitals which have got very old slit lamps, and they only have either the bulb is blown, so they are now in stores. You have OCOs who don't even have a torch, but they are there, sitting there. So there are no, actually, the equipment are not available, and if they are available, they are already, they are non-functional, and there's nobody to repair them. Some of them just require a bulb, but the system cannot allow it to be done. So this really make it very difficult to provide eye care services in most of these places. Then these simple diagnostic drugs, like fluorescent, methocaine, they are not there. Actually, what we call national medical stores don't have them. So and then these people have to get their supplies from national medical stores. So most of these regional referral hospitals and health center force and district hospitals cannot even provide basic eye care services, even if they have the manpower. So that is a very big barrier we have seen over this. Then for the regional referral hospitals, the ophthalmologists go there, they cannot do surgery because there is no intraocular lenses, plus the supplies for doing cataract surgery, the basic cataract surgery. They are not available at the regional referral hospitals. So services are actually not provided in most of these centers because of either manpower or consumables. Then, of course, for the lower units, the infrastructure. They have an OCO which they have just recruited, but there's no room for him to sit. Yeah. So we advocated, I remember by that time, with Dr. Kasadakao here, we said at least squeeze for them a chair and a table in a corner somewhere so that they do some little work. But they feel that they are not doing enough work, so they use them to do other work instead of eye care work. So those are some of the serious problems we face. Of course, the worst one, which I saw, actually, is the profile of eye care in this country. Even at the ministry level, we have issues with eye care. That's why initially it was under disability section of Ministry of Health. Now, at least we have moved a bit to clinical division. But the profile of eye care, you go to districts. The district chairman doesn't even know that that eye care exists. They don't. Actually, we went for an outreach to Kazu district in Nyambara. The chairman SC5 said, the DHO, actually, not the chairman, the DHO of Kazu district said for him, he thinks that there are no people suffering with eye problems in this district. So you can see the kind of how people perceive eye care because the profile is too low. I think the issue of advocacy needs to be taken seriously in this country if we need eye care to get more attention. Thank you.
Wow, this is amazing. Let's give him a round of applause. This, like I said, this is information that is not easy to find, and here it is. It's very sad to know that this is the kind of condition that the country is in. I know we're not holding anybody accountable, but we need to amplify our voices. A lot needs to be done, because if we have people in the different communities, I sat here when you said West Nile, and then my mind raced back to my village in Terego, and I asked questions of what will happen to a young girl in this community. What happens to, and then to make it even worse, that we have the staff, but they don't have where to sit. So this is also frustrating, even to the healthcare staff who are supporting this noble cause. It's good that we have our own Dr. Alex, who will speak to part of that at some point, where there are issues holding the ministry. I see you're smiling. My next question would go to Dr. Rebecca Clear. What are the most effective treatments for common eye conditions, such as pediatric cataracts and strabismus? You could speak to those very rare terminologies, yeah? I'm sitting here and asking myself, would I have managed it if I went to medical school?
Thank you, Moderator, for that question. Since you mainly mentioned two, as Dr. Nyango had already mentioned, there are many, but I'll focus on those two. So in the management of cataracts, which most people refer to as ensenke in Uganda, or opacity of the lens in the lay terms, we find that we have to start with prevention. When you're looking at management, it has grades, and the most important thing is prevention. From the day the mother gets pregnant, how can we prevent these children from having a cataract? I know that many mothers go for antenatal care, and most cases they are not told about conditions or infections that can lead to formation of a cataract in their newborn baby. And that means that we have to involve the obstetricians, we have to involve the midwives to actually give out this information. In case your child is born with a cataract or without a cataract, because as a mother you might not know what is supposed to be done, we need to take these children to hospitals. At least have one check before your child is 3 months of age to know, is the eye okay? Do they have a cataract? Do they have any other problem? And if there is a cataract, for that matter, there are some cataracts that we need to operate to remove so that we clear the vision of the baby. We clear the eye so that that child can see. And then there are some which we have to monitor. If the vision is good and the child still has a cataract, we monitor that child, but that means that the mother will need frequent checkups. So it all starts with coming to hospital. We need to evaluate these children. And as we have seen in the previous videos, for cataracts, the mainstay of treatment, if it's vision impairing, it's to have a surgery to remove it. And when we talk about strabismus, some people call it cross eyes, and Dali in Uganda, squints in lay terms, whatever you call it, or turning of the eye, it's treatable, yes, but there are many ways of treating strabismus. We start with what has caused it. Is it lack of treatment for a refractive error, whereby refractive errors you just need to give glasses for this child to actually have straight eyes? Is it because the child has a cataract that you need to remove first before you actually correct the eyes? So it goes back to the treatment, to the causes of that child having crossing of the eyes. And in case actually they have removed the cause and we need to correct the crossing of the eyes, sometimes it needs observation. You find that there are some babies who are born with crossing of the eyes early in their life, and as they grow, the eyes straighten. But you won't know that unless you come to hospital so that you can have a checkup and we give you our opinion. Some children we have to observe and see when can we do the measurements and actually do the surgery for you. So it's very, very important to have an eye exam, because at the end of the day, even if people think that crossing of the eyes is cosmesis, it is not entirely cosmesis. It can cause low vision in that eye, and if you have not removed the cause, there is no way of improving that child's vision. Yeah, thank you.
Amazing. Crossing of the eyes, I think I'll go with that. Are we here mothers? Yes, so I think I've picked something very key, that when you go for antenatal, Musa, you remember what you related it to. When you go to hospital for your routine antenatal checkups, you need to make it a point to ensure that you are aware of some of these conditions and how it can affect the unborn baby. But also that doesn't leave fathers, yeah? It is a collective effort. So you go together, and it should be your responsibility to also ensure that if your wife is pregnant, your child or your daughter is expecting, these are certain things that need to be put into place. Thank you very much, Dr. Rebecca. And I was here reflecting, wouldn't it be an easy way if this was partly integrated as information into the immunization schedules? Because for us, that one you don't want to miss. You set it, you make it a point. But then if it becomes, I am here guilty as charged. I have 3 daughters, but I've never thought of I should take that initiative. So thank you for that, Doctor. Let's move to Dr. Alex. Dr. Alex, remember Professor John mentioned certain key areas where your input could also be relevant by holding your office. So we're looking at which areas in Uganda are under served in terms of ophthalmology services, and why could that be the case? I know this has been touched by the 3 speakers before, but you can elaborate more on that. Thank you.
Thank you so much, moderator. Let me first of all make some corrections. When you were introducing me, my postgraduate diploma is for health leadership and management, not model.
Okay, that is noted. Thank you.
Yes. Okay. The question, as you have read it, this country, we still have a very big challenge as far as ophthalmology services are concerned. That is eye care. You find that the distribution of eye care workers in this country is not what a mathematical term really. It is not a normal distribution curve. It is skewed to urban areas, and therefore you find that services in the rural areas is actually a problem. You find that out of the 56 and also ophthalmologists that we have that are practicing ophthalmologists in this country, majority of them are in Kampala. Then you find another bigger group in Mbarara, and the rest of the urban centers, the municipalities, you find 1 or 2. Leaving the rural areas uncovered or underserved by those specialist services are not there. In this country, we have kind of strata, that's levels of services. We have the national referral, the regional referral, then the general hospitals and health center force. That's where our cadres end. In the national referral, we find there are senior consultant and other specialized eye care workers. And in this country, we have 3 government national referral hospitals, but we have also regional referral hospitals, which are almost serving at the same level like the national referral as far as eye care is concerned. So here, still it leaves the gap. We have those doctors there who are still not enough, but at least some few exist. And the rest of our hospitals have no specialized doctors. I want also to make some correction. Professor John was talking of how many, 7 regional referral that they lack. No, actually we have tried to make some improvement. At the moment, we are having 4 regional referrals without ophthalmologists. And these include Kayunga, Kabale, Arua, and Hoima. Those are the ones without ophthalmologists. For Yumbe, we have already got 1, and Entebbe has 1. So, at least we are improving, although still we have the challenges of wage. Because if we had the wage, then all of them would be covered. For the mid-level care, that's at the general hospitals. We are supposed to have OCOs and an optometrist. But it is so unfortunate that still wage for optometrist recruitment has not been realized, and we lack optometrists at all levels. So we are still struggling. We have some few OCOs in the general hospitals and some health center force. But the challenge is that what Professor John was telling us, that even in those centers, there is lack of equipment, and sometimes the physical infrastructure is not there. And therefore, the service delivered at such levels is minimal. However, we are still working around the clock with our partners, and I think in the future we shall get a breakthrough for equipment in particular. Because once the machines are there, at least that one can attract many people to come and work. The fact is that we have already trained manpower in place. The country has enough OCOs, has even ophthalmologists, they are there, but not yet recruited in the public service. So if the infrastructure is there and the equipment is there, There are those who are even willing to come and volunteer, give some services. But one cannot volunteer in a place where there is nothing to use. When it comes to that area of health supplies, medicines and health supplies, Dr. John Onyango has mentioned something. For us at the ministry, we have done what I think we are supposed to do, because I personally participated in the writing of the Uganda Clinical Guidelines 2023, and even the compilation of the Uganda Essential Medicines and Supplies list, where all those things used in theater for surgery, eye surgery, and the medicines or the drugs for both diagnostics and postoperative treatment were included. So, maybe what could be letting us down is now NMS. Because NMS has supplied the national referral hospitals. Here for them, they get the supplies. But when I ask my colleagues, my friends in the regional referrals, they don't seem to be getting these supplies. And I don't know why it is so. Anyway, those hospitals are self-accounting. So they know what is in their on their account. They should go ahead and check if they have the money. Let them ask for those things, because by putting them on the essential medicines and supplies list, it means we have instructed NMS to procure all those things, be ready to supply to the relevant entities.
Thank you very much, Doctor. I think picking from your explanation, it seems to be that there is a disconnect somewhere, either between the national, regional, or at the different levels. So probably the question is, what next? What can be done to avert some of these? It could be issues of human resource, equipment, or national medical stores. But I think somebody needs to be held accountable, right? So we need to amplify it further and also ensure that maybe some of them are not requesting for this because there are no staff or specialists in those areas who know that this could be one of the things that can get requested, or it could be lack of information, awareness, and all those other things. But it's good you've shared that, and we'll take note of it as well. Back to Dr. Rebecca. How can we overcome financial and logistical barriers that these underserved populations face in accessing eye care? So we're looking at the vulnerable communities, the people in the different communities where maybe access is not there, information is not there, communities that are really underprivileged. How can they be able to overcome this? Thank you.
Thank you so much for that question. So I think that will answer some of the questions you have been asking about the healthcare system and procurement, because it affects the logistical part of delivering services. But before I go into all this, we have to realize that ophthalmology is not a cheap discipline. The equipments are expensive, and the consumables are also expensive. So unless you prioritize it as government, as a country, many people will not pay attention to ophthalmology. So it needs a multifaceted approach from the government, from the communities, from the health workers, and the healthcare providers. When you look at the drugs that are provided that Dr. Alex was talking about, you find that at NMS there are none that cater for children. We don't have that foldable lenses that we can give to children. Yes, some of the drugs are cross-cutting, but the things for children are not there. Yet you have pediatric ophthalmologists in the country, and you expect them to actually offer a service. And if it's not for the other organizations that come in, like Light for the World, you find that people's hands would be tied to actually offer the service. And when we go down to the request for the consumables and the things that we need in the hospitals, he said they are provided for. If you are in a regional referral and the head is an obstetrician, and they need an obstetrician to carry out scissors or cesarean sections or deliver mothers, they will not need as much equipment as an ophthalmologist. So that person will prefer to hire a pediatrician, an obstetrician, and a physician compared to an ophthalmologist. And if you also consider equipment-wise and what we use to examine patients, they would rather get the drugs for malaria than actually order for drugs for eyes. So that's what they use their budgets for. And that has to be rectified. Because at the end of the day, if they do not prioritize eye care, we cannot move forward with this. Then in case we are to also subsidize the costs of eye care, we need the human resource. So we need to prioritize training. So far it's Makere and Bara that are training. And you can only train so much with the limited resources that we have. I'm sure Ambara would want to take on more, and Makere would want to take on more, given the resources. Because without the resources and the equipment that we need to actually train the doctors, we cannot take in any more numbers. Then we also have to look at the integration of services, like what you said. People go out and immunize. Every mother knows at 6 weeks, at this number of weeks, I have to go for an immunization. Ask them if they know anything about the eye. Pediatricians and healthcare workers are discharging preterms without giving them information that they are more at risk for retinopathy of prematurity. There are other complications they are more prone to that concern the eye, that they need to go for an eye checkup. This information is not needed, it's not included in the services that they give. So it's a bit difficult, as we heard from Greta's mother, used to go to hospital and they used to tell her the eyes are fine. And they never actually thought about sending this mother to an ophthalmologist for an eye checkup. Because you have come for immunization, I'm going to offer the immunization, that's all I can offer. So it needs to be integrated in the services that we offer. And we also have to look at other developed countries or developing countries. Not all the low-income countries have very poor eye services. Why? There are advances in technology. Medicine grows each and every day. There is telescreening, teleconsultation, which we can make use of in order to cut down the costs of transportation and in order to help that healthcare worker who is down there in the village and wants to offer a service or refer this patient to a specialist. Then we also have to make use of research in order to counteract the costs, because in developing sustainable and low-cost devices that can be used in the low-income countries like Uganda, we can be able to actually afford the equipment. I know with the Makere Research and Innovations Fund that's being funded by government, several studies have been done. And one of them is the Acolyte study to validate it for use in Uganda. And you find that if these equipments that are actually low cost are provided to the people who need them, then you won't find an OCO who does not even have a torch to examine a patient. So we need to embrace technology. We need to embrace the new advances in ophthalmology that are coming in and make use of them to actually tackle these problems.
That's amazing. Let's give a hand clap, please. innovations, technology. We can't continue to say that we're struggling, we're left behind. There are other countries in East Africa that we can also learn from. There's more that we can do as a country, not only as government, but even as partners that are walking this journey with the government in our different areas of interest. Thank you for sharing, Dr. Rebecca. Moving on to Professor John, what are some of the challenges that you do encounter in practicing pediatric ophthalmology in Uganda? And in what ways would you like to get support? It may not be from Light for the World, but how would things be done differently that it would make it easier for you? Please share your experience with us.
Thank you very much, Moderator. I will first start with some studies which we did in Barra. We did a 10-year follow-up of patients we treat for retinoblastoma at Ruharu Eye Center. And we published it in Cancer Epidemiology in 2020. Actually, 40% of children with retinoblastoma we treat at Barra will die. That is 4 in 10. Why? Because they present late. So late presentation of almost all cases of pediatric eye conditions present late. You find a child coming with a cancer which is really protruding on the face like this. You wonder where they have been living. Yes, that is a very advanced cancer which has really spread to the brain and spread everywhere. So whatever you do, you will never save that life. So 40% die because of late presentation. We did a survey in Tungamo district in 2015 of childhood blindness. And what did we find as the leading cause of blindness in children in Tungamo? Operated cataract, not cataract, operated cataract. Children who have undergone operation for cataract, but they are the ones with the visual impairment and blindness. Why? Again, late presentation. The children were operated when they were 10 years. I said, for children, if you want to save life in a child, it must be operated before 8 years. So if you bring a child who has been having cataract for the last 10 years, whatever you do, you are not going to change anything. Vision will never develop. So late presentation of cataract was the cause of the poor vision in the children who are operated. So that is one. So late presentation of almost all the cases is our biggest issue, which should be addressed through awareness and sensitization of the community. Of course, some of the children in Tungamo who had poor vision were operated early, when they were 2-3 years. And you see greatest there, what is she putting on? Glasses. You can never operate on a cataract if you have not planned to give spectacle correction post-operatively. But we have had projects here. I remember we had a project with we were sponsored by Standard Chartered Bank, was also seeing is believing. Those issues were very pertinent when we were raising in that thing. We were operating, but no spectacle correction were being provided. You cannot go and start operating a child if you are not ready to provide spectacle post-operatively. And this is supposed to be done at a very regular, for example, if you operate a child below 1 year, it is supposed to be changed after every 3 months. After 2 years, you are going to be changing it after 6 months. So the regular change of spectacles, if it is not in your budget for that project, then you don't need to start it. Because at the end of the day, we shall go back to Ntungamo, where a majority of the children we operated are the ones which are blind. Yeah, so those were the challenges. Lack of corrective devices. And then for those ones who get visually impaired, they are languishing in the village there. Some of them have been sent to the school of the blind. And yet they could go to regular schools if we are giving them low vision corrective devices. They are not there. So we need low vision corrective devices for some of these children who are already visually impaired. They have low vision. But when they give them those devices like a telescope, magnifying, they can go and study in the regular school with other children, avoiding stigma. And the other one, of course, are, again, manpower. When you are having a child, when you're having a child, assessment of a child is not as easy. Not all health workers can assess a child. You need some specialized service like the low vision specialist who can assess a child with low vision, measure what kind of devices they need. So those, we don't have all those. When I talk about low vision specialists, actually in Uganda, I know they're in Mengo, they're in Ruharo, and probably in Benedictine. The rest of this country, there are no low vision specialists. So where do you expect those students to get the services? So we need appropriate manpower. I'm glad Dr. Naomi has now brought in the optometrists, because we need, these refractionists, OCOs cannot do this refraction in children. We need an optometrist who is well trained to do that. So we have the optometrists, although they are still not yet deployed everywhere. So again, appropriate manpower which are needed to do that is also another challenge. We don't have them. And so the services are limited in very few areas within the country. Again, we go back to equipment. There are very many places. I know Lisbon is the ones who can do cataract surgery accurately in a child by measuring the power of the lens he wants to put in a child. Because and other places people just estimate. You use the age of a child and say this child is 3 years, so I'm going to put a power of 23, 20. But that is estimate. We are all different. So we need appropriate equipment like the keratometers, where you can use portable keratometer to measure when the child is on table. So we don't have the equipment appropriate to do some of those. And so that means that the outcome of whatever we do will not be as accurate as possible, which in turn will affect the children's future. Thank you.
Amazing. And to think that the theme says a clear future, safeguarding children's eye health in Uganda. You just had Professor say 40% of those who went through the surgery died. And I think it's very clear that you don't start what you cannot finish. If the interventions are to start a process and not to conclude, it's advisable probably to continue creating awareness, giving out information, and looking for more resources. With everything, it comes back to resources, it comes back to intentionality, it comes back to that deliberate move of us saying that we need this, because today it could be Greta who is here